What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about strokes, both ischemic strokes and hemorrhagic strokes. We talked about the Cushing triad or the Cushing reflex. We talked about the different types of shock. We talked about the Glasgow-Coma scale, and we talked about the different pathways of dopamine, as well as neuropharmacology. Then we started pathology by talking about the diseases that cause muscle weakness. We talked about Duchenne muscular dystrophy and Becker's muscular dystrophy. We talked about Guillain-Barré syndrome, and we talked about multiple sclerosis. In the last video, we talked about myasthenia gravis. As for today, we shall discuss Lambert Eaton Myasthenic Syndrome. Some people call it Lambert Eaton, others call it Eaton Lambert. What's going on in this disease? It's an autoimmune disease where I have nasty autoantibodies attacking the presynaptic voltage-gated calcium channel, which leads to decreased acetylcholine release, which causes muscle weakness. But how can we distinguish between Lambert-Eaton and myasthenia gravis? Let's find out. Click the like button, click the subscribe button, and let's get started. I have two playlists talking about neuro. One is called neuroanatomy for anatomy, and one is called neurology, which has anatomy, physiology, neuropharmacology, and pathology. Diseases that can make my muscles weak could be problems in the central nervous system, such as brain and spinal cord, and myasthenia gravis falls into this category. Or it could be a disease that affects the radicals, or the nerve roots as they exit the spinal cord, or a disease that causes peripheral neuropathy, or a pathology in the peripheral nerve. If you remember, Guillain-Barré syndrome is both a radiculopathy and a peripheral neuropathy together. It's going to hit me here and here. After this, we have diseases of the neuromuscular junction, including myasthenia gravis, see the previous video, and Lambert-Eaton Myasthenic Syndrome, which is today's topic. Next, some diseases affect the muscle itself, such as muscular dystrophies, and we talked about these before, such as Duchenne muscular dystrophy and Becker's muscular dystrophy. Then we have metabolic myopathies and congenital myopathies. If I have a disease in the brain, it's called encephalopathy. If I have inflammation of the brain, it's called encephalitis. If I have inflammation of the meninges that surround the brain and the spinal cord, we call that meningitis. If I have a disease in the spinal cord, it's called myelopathy, pathology of the core, because the spinal cord is in the core of the vertebral column. Radiculopathy is pathology of the nerve root as it exits or as it enters, depending on how we look at it. Peripheral neuropathy is a pathology of the peripheral nerve, and between the nerve and the muscle we have a neuromuscular junction, or the synaptic cleft, or the motor end plate. After this we have the muscle. Which of these areas is destroyed in Lambert-Eaton? The answer is the neuromuscular junction, because we are attacking the presynaptic axon knob. If you wish to download these colorful notes, go to medicosisperfectionalis.com. If you want me to personally tutor you, reach out to me on my website. Does Lambert-Eaton Myasthenic Syndrome affect the brain and the spinal cord, i.e. CNS? The answer is no. Does it affect the peripheral nerves? Well, not the nerve itself, but the last part of the nerve, the axon terminalis. These are the ones that are damaged in the neuromuscular junction or the motor end plate. If you want to see more videos like this in the future, please drop a brain emoji in the comments. Remember that we have this is a nerve, this is the axon terminalis, or the terminal axon knob. This is a skeletal muscle in this case. Now we have a disease that's going to attack the presynaptic voltage-gated calcium channels, and we have another disease that will attack the postsynaptic acetylcholine receptors that happen to be nicotinic sub-M. M for muscle. Nicotinic because nicotine can stimulate them. Now please pause the video and try to answer these two questions. Which disease attacks the presynaptic voltage-gated calcium channels? And what's the name of the disease that attacks the postsynaptic nicotinic sub-M acetylcholine receptors? What are the answers? The first disease is Lambert-Eaton Myasthenic Syndrome, and the second disease is myasthenia gravis. Lambert-Eaton Myasthenic Syndrome attacks the presynaptic voltage-gated calcium channels, whereas myasthenia gravis attacks the postsynaptic acetylcholine receptors which happens to be nicotinic sub-M. Before we understand the pathology, we need to talk about the physiology. Physiologically speaking, you need to stimulate the nerve first, and then the nerve will stimulate the muscle, and then the muscle will contract. So we need an action potential inside the nerve itself. Hashtag sodium influx, hashtag depolarization. After this, the action potential will pass down the nerve, just like the shock that passes down the spine of a patient with myasthenia gravis. Remember the positive Lermite sign. After the action potential passes down the nerve, we're going to open voltage-gated calcium channels, so calcium goes in. When calcium goes in, calcium is the hero of contraction, so this vesicle will contract and release the acetylcholine out of the nerve, hashtag exocytosis. Then the acetylcholine will act on the receptor. In this case, we have a skeletal muscle, and the name of the receptor on the skeletal muscle is an acetylcholine receptor, which is nicotinic sub-M. After the acetylcholine binds to its receptor, the muscle will generate its own action potential and the muscle will contract. Now, what if we have a disease that attacks the presynaptic voltage-gated calcium channels? What's going to happen? Calcium is not going to be able to enter into the axon terminalis. The vesicle will never rupture, acetylcholine will not be released, and the muscle will not contract. So what will I get? I'll get muscle weakness. Speaking of calcium channels, how many types are they? There are bazillion types of calcium channels. Here are the most common ones. We have the L type, the T type, the N type, the P/Q type, and the R type. The L type is in the heart, some skeletal muscles, smooth muscles, and neurons. T type is in the SA node of the heart. It's also in the brain. The N type is in the presynaptic axon knob. The way I remember this is that the N is in the axon terminalis. Then the P/Q type, we find this in Purkinje, P for Purkinje, and we also find them in the presynaptic axon knobs. Then the R type is in the cerebellar granular cells and in other neurons. Which one of these types of calcium channels is attacked in Lambert Eaton Myasthenic Syndrome? The answer is the P/Q type. In the presynaptic axon knob of motor and autonomic fibers. Do you remember my videos on the autonomic nervous system? See my physiology playlist and my neurology playlist. We talked about all types of fibers. We have cholinergic fibers. All of the preganglionic fibers are cholinergic. And then the postganglionic fibers could be cholinergic or adrenergic. If we want to reach a skeletal muscle, which is a voluntary muscle like your biceps, triceps, quadriceps, etc., then the fiber will release acetylcholine and the receptor weighting will be nicotinic sub-M. Let me ask you this. Do these fibers have presynaptic calcium channels? The answer is yes. So therefore, can they get damaged in Lambert Eaton Myasthenic Syndrome? Yes, they can get damaged in Lambert Eaton. How about the fibers that go to the ganglion? Do they have acetylcholine? Yeah. Do they have presynaptic calcium? Yeah. Can they get affected in Lambert Eaton? Absolutely. And this is true whether you are parasympathetic or sympathetic. Therefore, we can deduce that Lambert Eaton Myasthenic Syndrome will have somatic motor symptoms and autonomic symptoms. However, myasthenia gravis is different because myasthenia gravis only affects the nicotinic sub-M, and you only find these types of receptors in one type of tissue only, which is skeletal muscles. So in myasthenia, only the skeletal muscles get affected. But in Lambert Eaton, the nerves that supply the skeletal muscles get affected, the nerves that supply the smooth muscles get affected, and the autonomic fibers get affected. So in Lambert Eaton, it's not just motor symptoms, but motor and autonomic symptoms. This is the upper motor neuron. Don't care about it. This is the lower motor neuron. Of course, I care about it because it has an axon terminalis, which has calcium channels, and Lambert Eaton Myasthenic Syndrome will hit me here. How about these cranial nerves? Do they have an axon terminalis? The answer is absolutely yes. So, do you think that Lambert Eaton Myasthenic Syndrome can affect them? Yes, of course. However, when it comes to the ophthalmoplegia and the muscles supplied by the cranial nerves, they are more likely to be affected in myasthenia gravis when compared to Lambert Eaton Myasthenic Syndrome. What is Lambert Eaton Myasthenic Syndrome? It's an autoimmune disease where we have autoantibodies against the presynaptic voltage-gated PQ calcium channels on the nerve terminals. Some of these nerves are somatic motor, others are autonomic nerves. And we have two types of Lambert Eaton, the one that has cancer and the one that's not related to cancer. What cancer are we talking? Most of the time it's small cell lung cancer. Epidemiology of Lambert Eaton Myasthenic Syndrome. The peak incidence is between 50 and 60 years of age. It's more common in males than females, but myasthenia gravis was the exact opposite. Myasthenia gravis was more common in females. About 3% of patients with small cell lung cancer develop Lambert Eaton Myasthenic Syndrome. From the other perspective, 60% of patients who have Lambert Eaton Myasthenic Syndrome have small cell lung cancer. And this right here is a difference between the mediocre doctor and the good doctor. The mediocre doctor will say, "Oh, I diagnosed Lambert Eaton Myasthenic Syndrome. I can't believe I did it. That's hilarious." And then that mediocre doctor will prescribe some medications and call it a day. However, the excellent doctor will say, I found Lambert Eaton Myasthenic Syndrome. What else could be there? If I found a needle in a haystack, maybe, just maybe, there is a second needle and a third needle in the same haystack. About 20% of patients with Lambert Eaton Myasthenic Syndrome, which is an autoimmune disease, have another autoimmune disease. Which reminds me of Warren Buffett when he said, quote, "There is seldom one cockroach in the kitchen." Autoimmune diseases are like birds of feather. They flock together. If I have one autoimmune disease, it's likely that I have another autoimmune disease. Clinical picture of Lambert Eaton Myasthenic Syndrome, we have the symptoms and the signs. What's the difference? The symptom has Y in it, so you, the patient, will tell me what's up. But the word sign has an I in it. I, as a doctor, is going to discover something by physical exam. Symptoms. The patient will complain of muscle weakness that improves with brief exercise. We call this post-exercise facilitation, and this is important. The weakness is more proximal than distal, and it's more likely in the lower extremity. So proximal lower extremity weakness, the patient will say something like, "Doctor, I have hard time walking upstairs," or "I have hard time rising from a chair." Because to do these, I need powerful thigh muscles and powerful hip muscles, and these are proximal muscles. Unlike myasthenia gravis, which did not have any autonomic symptoms, Lambert Eaton does have autonomic symptoms. What do I mean by this? Dry eyes, dry mouth, xerophthalmia and xerostomia respectively, blurry vision, orthostatic hypotension. If I were lying flat on bed and I suddenly stood up, I will get hypotension and tachycardia beyond a certain threshold, and this is called orthostatic hypotension. The word ortho means straight upright. And Lambert Eaton is also associated with sexual dysfunction such as erectile dysfunction. Signs. On physical exam, the muscle strength is decreased, of course, because the calcium channels are attacked. No calcium influx, no exocytosis of acetylcholine, no skeletal muscle contraction, so of course the muscles are weak. The deep tendon reflexes are weak, because for the reflex to happen you need what? You need an efferent and an effector organ, and these will not work if I have Lambert Eaton Myasthenic Syndrome. However, there is something crazy about these deep tendon reflexes. If you keep repeating the same tendon, tapping the same tendon, performing the same deep tendon reflex, the patient's reflexes will tend to improve the more you tap. So do not give up on your patient. If you remember myasthenia gravis in the previous video, we said that myasthenia has lots of ocular symptoms and lots of bulbar muscle weaknesses. However, in Lambert Eaton, the ocular and the bulbar muscles are usually normal. To learn more about the bulbar muscles, please refer to the previous video. The clinical variants of Lambert Eaton, well, most Lambert Eaton Myasthenic Syndrome are part of a paraneoplastic syndrome. What does para mean? Parallel. Neo, new, plastic, growth. Oh, this is referring to neoplasia or cancer. Yes, because many patients with Lambert Eaton have lung cancer or another cancer. However, that's not always the case. Some patients have Lambert Eaton without a cancer. So if you are a doctor and you diagnose Lambert Eaton, we're not done yet. You need to check if the patient has cancer or not. How can we diagnose Lambert Eaton Myasthenic Syndrome clinically? By signs and symptoms. Electromyography with nerve conduction studies. What do we find? Muscle weakness. More than 10% decrease or decrement in motor amplitude. However, if you exercise for 10 seconds, you'll have more than 100% increment in motor amplitude. Hashtag post-exercise fasciculation. You can look at the serum for antibodies against presynaptic voltage-gated PQ calcium channels. You can do CT scan of the chest or a PET scan to look for the nasty lung cancer, because Lambert Eaton could be a paraneoplastic syndrome. If you have watched my pharmacology videos on opioids, you will remember that opioids are potassium channel openers. When you open potassium channel, potassium is going to leave. When the positive ion is leaving the neuron becomes inhibited. And by inhibited, I mean calcium will not enter. And if calcium is not entering, acetylcholine, or whatever the neurotransmitter might be, is not going to be released. So by taking opioids, I'm decreasing the release of neurotransmitters. And that's how they decrease pain. But what if I did the opposite, such as with this fancy schmancy medication, which is amifampridine? Instead of opening the potassium channel, I'm going to close it. And if I close it, what's going to happen? Potassium will accumulate inside. This is a positive ion piling up inside the nerve. This excites the nerve, hashtag depolarization. When the nerve is depolarized, calcium channel will open and calcium will enter more. Calcium will rupture more acetylcholine vesicles and release more acetylcholine at the neuromuscular junction. And that's why this medication can be used to treat Lambert Eaton Myasthenic Syndrome by forcing the calcium in against the will of the nasty autoantibodies that are trying to inhibit the channel. Treatment of Lambert Eaton Myasthenic Syndrome, via negativa before via positiva. What should I avoid? Try to avoid aminoglycoside antibiotics such as gentamicin, neomycin, amikacin, tobramycin, streptomycin. Avoid beta blockers. Avoid class 1 antiarrhythmics. Can you give me 2 examples of class 1 antiarrhythmics? Please comment below. Quinolone antibiotics, succinylcholine, and tupicurarine, which is a curare-like molecule. And what does curare do? Curare is a neuromuscular blocker. Oh, I do not want that because my neuromuscular junction is already suffering because of my Lambert Eaton, so I'm not going to take any of these. If there is a lung cancer, make sure to manage that cancer. Then, since Lambert Eaton is an immune disease, it's an autoimmune disease, we give immunosuppressants such as prednisone or azathioprine. The same story holds true for myasthenia gravis if you have watched the previous video. I can give intravenous immunoglobulin. How do these work? This is like throwing a stick to a dog. And when you throw the stick to the dog, which is the antibody, is gonna bind the stick and forget to attack the calcium channels. So the calcium will enter, the vesicle will rupture, and the muscle will contract. Plasma exchange, take the patient's plasma, which contains the nasty autoantibodies, remove the antibodies, and then return to the patient clean plasma. Amifampridine inhibits the presynaptic potassium channels, which depolarizes the neurons, meaning it activates them, which opens the calcium channels, increasing the concentration of calcium in the presynaptic axon terminalis, which boosts the release of acetylcholine by means of exocytosis. Acetylcholine is going to bind to its receptor on the muscles, whether they are skeletal or smooth, and this will improve the contraction of the muscles. Let's summarize Lambert Eaton in 1 minute. The typical patient is 50 to 60 years old, usually male, but could be female as well, and usually has lung cancer, such as lung cancer. Muscle weakness that improve with exercise and worsens with rest. This is post-exercise facilitation. The exact opposite happens in myasthenia gravis. Proximal lower limb muscles are commonly affected, so I have hard time walking upstairs and difficulty rising from a chair. Autonomic symptoms can happen, such as orthostatic hypotension and erectile dysfunction. Physical examination, the muscle strength is diminished, deep tendon reflexes are diminished, and this can be improved by not giving up on your patient and keep tapping the same tendon. It will get better. How can I diagnose Lambert Eaton Myasthenic Syndrome? Clinically, by signs and symptoms, electromyography and nerve conduction studies. Look for the post-exercise fasciculation, and you can look in the serum for the antibodies that are attacking the presynaptic PQ calcium channels. CT scan of the chest to look for lung cancer. Treatment is immunosuppressants, IVIG, manage the lung cancer, and amifampridine. Let's answer the question of the previous video. In Guillain-Barré syndrome, the deep tendon reflexes are what? Is it decreased, increased, or normal? Please pause the video and try to answer this. The correct answer is absent because of the demyelination of the peripheral nerves. In myasthenia gravis, the deep tendon reflexes are. The answer is normal. Let's add a question here. In Lambert Eaton Myasthenic Syndrome, the deep tendon reflexes are. The answer is diminished in Lambert Eaton. Next, in Guillain-Barré syndrome, the muscle weakness is mostly proximal or distal. The correct answer here is distal. In myasthenia, the muscle weakness is mostly proximal. As for today, I have a very long case for you. Please pause the video and read it. Here is the first question for that case. Here is the second question for that case. And this is the third question for the case. Let me know the answers for these three questions in the comments. You will find the answer key in the next video. Do you want to learn about adrenergics, cholinergics, anticholinergics, the alphas, the betas, the muscarinics, the nicotinics, and all of this lovely stuff? Download my autonomic pharmacology course at medicosisperfectionalis.com. It comes with videos, notes, and cases. Do you want to learn about strokes, myocardial infarction, cardiac arrhythmias, ARDS, acute limb ischemia, endocrine emergencies, drowning, toxidromes, and more? Download my emergency medicine high yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about neurosurgery, cardiothoracic surgery, trauma surgery, pre-operative care, post-operative care, ophthalmological surgery, and more, download my surgery high yields course at medicosisperfectionalis.com. And to learn about opioids, anesthetics, stimulants, sedatives, hypnotics, anti-epileptics, antidepressants, antipsychotics, and anti-Parkinsonian medications, download my neuropharmacology course on my website. If you found these videos to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.